pleasure to talk about transposition of the great arteries. It's an issue that personally I like so much, and all the Brazilian pediatric cardiologists like, because Dr. Adib Chateni contributions in the surgery. Okay, I'll start just to show the focus in a diagnosis of a baby, a newborn with cyanosis, severe cyanosis. This is our baby, male term, newborn, that with cyanosis in the first hours of life. This is the pulse oximetry, 99%. This is in the foot. Tachypnea without heart murmur. These are dangerous for the new pediatrics and the neonatology. Most 50% at least of the DTJs, there's no murmurs, and you have to think about this condition even without murmurs. And what we will do, you do oxygen to the baby. This is now into with tube, with mechanical ventilation in the ICU. Take blood arterial gas, and the first PaO2 in room air about 35 millimeters of mercury, and after increase the FiO2 100%, just a small increase, 40 millimeters of mercury. This is the high peroxide test, and you have to think in cyanotic congenital heart disease when you have this result. A small or no increase of pulmonary oxygenation of the arterial blood. Then do an X-ray, a chest X-ray, and if you look without small attention, oh sorry, you can. Some people can say that this heart size, it's a normal heart size, but looks like an egg shaped. The X-ray is important to exclude lung disease. The lung is normal, and to see the pulmonary vascularity, that is quite small in this newborn. And it's another detail. The upper mediastin is quite narrow. The narrow mediastin and the egg-shaped cardiac size, we have to think in the transposition of the great arteries. The ECG doesn't help us so much, because they showed the right ventricular hypertrophy, right X deviation, and right force in the precordial leads, but it's normal in the newborn. That's not a specific ECG for the transposition. And finally, you take the echocardiogram and do the diagnosis. You see in the subcostal view the right ventricle arising from the right ventricle, the aorta, and the left ventricle arising the pulmonary artery. This is the bifurcation. This is the ductus arteriosus. There's a red flow from the ductus. Okay, then the diagnosis is made. Okay, definition. So the definition of DTGA is that the aorta arises from the right ventricle, like you see in this beautiful image, aorta arising from the right ventricle, and pulmonary artery arising from the left ventricle. Okay, in other words, you can say that we have concordant atrioventricular connections, right ventricle, left ventricle, with discordant ventricular arterial connections, right ventricle aorta, left ventricle pulmonary artery. This is the DTGA. Prevalence. 5 to 7% of all congenital heart disease, but the number is not so impressive. But if we think about cyanotic newborns, DTGA is an important issue, it's an important pathology that we had known. Tetralogy of Fallot and the DTGA is the most common cyanotic congenital heart disease, like you say. And males, 60 to 70% are males. Okay. The pathology, You say this anatomy specimen, the right ventricle is open. You see the tricuspid valve, the tuberculation of the right ventricle, the infundibulum, septum, and the aorta. Okay, with coronary arteries origin here. The left ventricle is open with the typical trabeculated, the mitral valve, and the pulmonary artery, the pulmonary trunk, and the bifurcation. In the right picture, you see again the right ventricle, the aorta. This is the coronary artery orifice, and the left ventricle and the pulmonary artery. Short trunk with the bifurcation. Um, Associated defects, other than PFO and PDA that almost all newborns had. VSD is an important associated defect, 40 to 45%, but 1/3 of these are small VSDs. Left ventricle outflow tract obstruction with VSD, 10%. Left ventricle outflow tract obstruction without VSD with intact ventricular septum, 5%. Abnormal coronary arteries anatomy are present in 30%. This is important for the surgery for we program there to switch arterial. Aortic arch abnormalities are very common, interruption or coarctation, and atrioventricular valve abnormalities may be with VSD. Okay. The great arteries relationship is an important issue in the DTGA. In general, the majority of cases are the oblique positions with the aorta in front, anterior, and quite to the right, and the pulmonary artery posterior and quite to the left. Like you see in this specimen, anatomic specimen, that you see the aorta, the right coronary artery on this right facing sinus, and the left coronary artery from the left facing sinus, the pulmonary artery with the valves, okay, in this oblique position. It's important, but it's the most case. But we have cases that the arteries are side by side and case in the anterior or posterior. The coronary arteries, this is important. We know that in almost 6-7%, we have the usual arrangement. The usual arrangement is that we have in the right facing sinus, the right coronary artery. Let's see this three-dimensional approach that is quite easy to understand. It's the view of the surgeon. Then in the right facing sinus, the right coronary artery, in the left sinus, the left coronary artery, the left anterior descending, and circumflex. Okay, the most common abnormalities of the coronary arteries in 16% is the circumflex from the right coronary artery. Then you see in the right coronary artery and the circumflex here, and the way behind behind the the pulmonary artery, and a single left descending aorta in the left facing sinus. There's a many other arrangements: single left coronary arteries, single right coronary arteries, inverted origins. Okay, and this is important to know, and to the cardiographists needs to search for this alteration, because this can difficult the arteries for each operation. Its name is intramural coronary arteries. What is intramural coronary arteries? In general, the coronary arteries are rising from another location and take a place into the walls of the aorta, and goes out, arrive in the take off in another position. This segment inner the wall of the water or aortic wall may difficult the surgery procedure. Okay, the left coronary artery may be intramural and the right coronary artery too. We suspected of this in echo, like you see in these pictures, when the echocardiographer see a coronary artery between the two great arteries. Okay, it's a few cases, but it's important to know this. Pathophysiology. The normal circulation is a serious circulation. Okay, our circulations is something like this. The desaturated blood with low saturation from the body through the systemic venous arrive the right atrium, right ventricle, coronary artery, go to the lungs, turn now to receive oxygen, and the oxygenated blood goes through the pulmonary veins to the left atrium, left ventricle, aorta, and body again. This is a serious, okay, circulation. The DTJ, the single changed switching the aorta from the right ventricle and the pulmonary from the left ventricle created two parallel circulations. The systemic circulations is with a low saturation. Okay, the venous return with low saturation, desaturated blood, arrive at the right ventricle, and again the systemic circulation. Very low saturations in this side and high low saturations in this side. The oxygenated blood from the lungs arrive at the left atrium, go to left ventricle and pulmonary artery again. This is terrible and incompatible with the life without the some places for mixing the blood. Okay, the right atrium, the atrial septum is the best place to increase the systemic saturation. Here's the place where we can move oxygen from the left side to the right side and go to the body. It's the best way, the ASD. A VSD is good too, but the VSD is more important to keep the pressure of the both ventricles similar. You see in the next slide, you see that when the days pass, the pulmonary vascular resistance will be low, and the pressure in the pulmonary artery will reduce, and the left ventricle will work with low pressures and may lose muscles and be unprepared to receive the aorta circulation with high pressures after the arterial switch operation. Okay, and the PDA is so important to mix it to increase the saturation of the systemic circulation, and the medications to keep this open is important. I will try to. This is from Park's Pediatric Cardiology. I really appreciate this book. It's very, very good. And these diagrams are from the book. And correlation. I do the correlation about the pathophysiology and clinical manifestations. First, DTGA without VSD, with intact ventricular septum. There are two scenarios with just a POF or a restrictive ASD. Okay, poor mixture. Okay, see into the chambers the saturation and out the pressure. Okay, systemic events 30% of saturation. In the atrium, a little small increased because the mixing is poor, is a small orifice here, 30, 45, 45, and 45 to aorta. It's not a good, the baby will be bad. And the other side, 100%, 92% because the mixing, 92% and 92%. And again, what will be this baby with severe cyanosis in the first day of life, tachydyspnea, without murmurs, because there's no conditions to create a murmur here, and loud and single S2. The aorta is anterior in the most people, in the most DTGAs. In the other side, when we have a large ASD, we can we have a more mixing, blood mixing here, and the saturation is much better. In this diagram, 65 here, arriving in the right atrium, increase to 80 to the ventricle and 80 to aorta. Okay, it's like much better. And the other side, 190, 90, 90 to the lungs. And this baby, mild cyanosis. Okay, this baby may go to home without the diagnosis if we don't do the pulse oximetry screen, okay, before the discharge of the hospital. It's an important tool that we have now to diagnose this cyanotic congenital heart disease without many signs. Other conditions, the DTGA with VSD, large VSD, okay? Small VSD is not hemodynamically significant. With a large VSD, we have not much increase in the saturation, systemic saturation, but we have uh, keep the pressure of the two ventricles similar, okay? Because it's a large ESD, we call the pressure, and the left ventricle don't falls down, will be unprepared to switch arterial. Okay, this is the most important of this condition. But on the other hand, this kind of children have much pulmonary blood flow, okay, and dilated heart and heart failure. Okay, mild cyanosis, the saturation is 75. In this example, congestive heart failure after 1-2 weeks, tachycardia and tachydyspnea, loud and split S2, early or hollow systolic murmur of VSD. This is the DTGAs with murmur. Okay, the VSD may make this noise. And another feature of DTGA is that one with VSD and pulmonary stenosis. Like in this scheme, we don't have dilatation of the heart. You have poor systemic saturations. Why? In this example, there's no ASD. That is good to increase systemic saturation. There's a VSD that's just is good for the left ventricle pressure and hypertrophy of the right ventricle because it's the left ventricle outflow tract obstruction. Okay, this is the child with severe cyanosis. We can have a soft mid-systolic murmur of coronary stenosis, the left ventricle outflow tract obstruction. Okay, this is the three scenarios, the four scenarios, the small ASD, the big, large, small ASD, large ASD, large VSD, and large VSD with a pulmonary stenosis. Okay, again, the diagnostic studies, electrocardiogram, like I said before, right ventricle hypertrophy. This is the same electrocardiogram, but it's normal in the neonate. X-ray, chest X-ray, the typical you see in this X-ray before. You see the egg-shaped cardiac silhouette with a narrow superior mediastinum. In the other hand, with a large VSD, you can see cardiomegaly with increased pulmonary vascularity. Okay. The echocardiogram defines the anatomy, including coronaries, identifies the presence and size of the ASD, identifies the presence of a PDA, determines the degree of shunting, identifies any associated cardiac defects. Here is an echocardiogram, a fetal echocardiogram. And, this is an ideal condition, the diagnosis intra-utero. You can see here in DTG, the 4 chambers is normal. Okay, right atrial connecting to the right ventricle, and the left atrial connecting to the left ventricle, concordant connections. And when you look at the outflow tracts, you see the left ventricle connected to the pulmonary artery, and the right ventricle connected to the left anterior aorta. In these situations, you see both arteries in parallel positions. In a normal outflow tract, they are crossing each others, and there is no parallel like this. And just these two images for the fetal echocardiographist can get diagnose the detransposition of the great arteries. Another echo of a newborn showing you the position of the aorta and the pulmonary artery. This is anterior, okay, this is posterior, this is the right side, this is the left side. Then the aorta is anterior and to the right, oblique, the pulmonary artery, oblique position. And this is a quite good image that we can see the coronary arteries. This is a impressive image that is not so easy to do that. It's not common. You can do the same images like this. You can see the right coronary artery from the right facing sinus and the left coronary artery with flow from the left coronary facing sinus. Other important role of the echocardiogram is to analyze the ventricular septum geometry. Why? The ventricular septum in echo is a easy image to require. It is a parasternal or a subcostal short X view of the left ventricle. Then see the left ventricle and the right ventricle. This is a large enlargement of the right ventricle with the increased thickness of the right ventricle wall. And here the septum is rectified. What does this say to us? That the pressure in these two ventricles are similar, are the same. Okay, this left ventricle is prepared to receive the aorta and the systemic circulation after the arterial switch operation. In this side, we say that this type 2 septum and this type 3 septum. You can see that the septum bulges to the left in the systolic phase. Then what this can say to us? That the right ventricle pressure is higher than the left ventricle pressure. Then this left ventricle is not prepared, is unprepared to receive the aorta and the systemic circulation in the arterial switch operation. This image, I think that is a higher image. This is an old image from the cath lab. Why? Because it's not necessary cardiac catheterization for the diagnosis. The echocardiogram do what it needs. When you can think about cardiac catheterization, may be indicated if the coronary artery anatomy is in question, may be indicated for atrial septostomy, like you see in the next slide. This side, we can see the contrast in the right chamber with the the large tuberculations and the aorta, and the other side contrast in the left ventricle and the pulmonary artery, the discordant ventricular arterial connection. Natural history. Progressive hypoxia, acidosis, heart failure, and death. And this is a special paper from in Circulation 1969, the natural history without procedure of the TGA with intact septum, no VSD in this curve, and in this curve all TGAs, including the VSD. What can I say here? That the mortality is so high, it's impressive. If 1 week of life, 1 week, 7% just alive. In 1 month, without VSD, 30% of the babies are alive. It is a great mortality, and without VSD, no one reached 1 year of life. It's terrible condition, okay? The VSD in pulmonary storage and pulmonary stenosis may increase quite a little the survival, but it's terrible too. Medical management, okay, you have to do oxygen, correction of the acidosis, hypoglycemia and hypocalcemia, Prostaglandin is the safe, is a excellent medication and really can save lives. The prostaglandin keeps open the ductal arteries and possibility a place to mixing the oxygenated blood. Inotropic and diuretics if heart failure. And the nature story of the DHA started to be changed in 1966 with Dr. William Haskin that created a procedure. This is a schematic, and you can see a catheter balloon introduced by the inferior venous cava, crossing the atrial septum. Start again. Okay, inflated a balloon and pull back to open the ASD and improve the systemic saturation. Okay, indications: indicated atrial mixing through inadequate atrial mixing through the PFO. How can we diagnose here? High Doppler flow velocity of more than 1 meters per second in the echocardiograph, significant hypoxia, metabolic acidosis, signs of poor mixing in the atrial level, or lack of readiness of surgical interventions. Some reason that you can do the arterial switch in the first or second week of life, you can ampliate the atrial septum defect to improve the systemic saturation. Traditionally, the balloon atrial septostomy were in the cath lab. This is our cath lab. Dr. Monsieur Godoy, the anesthesiologist. Unfortunately, this anesthesiologist is in the hospital with COVID coronavirus, but I think that he is well now. The echo machine, okay, and this is the image that you see. The catheter balloons pulled back to ampliate the atrial septum defect, and this is the probe, the echo probe, to guide the exam. This is a better condition, the ideal condition. Now we know that balloon atrial septostomy it's better to do it in the ICU. The baby is not removed from the bedside. The temperature is more controlled. We have this is the Dr. Monsieur, our pediatric interventionist. Dr. Ana Carolina, my friend, pediatric cardiologist and intensivist. This is a fellow of the hemodynamic the hemodynamic series, and this is me with the echo machine. You can see far from the right atrium, left atrium, and the septum. And this is a small video that I show. Sorry, because this is in Portuguese, but it's just to show the procedure guided by the echocardiography. First, catheter in the inferior vena cava and right atrium. Here, catheter, vena cava, right atrium. 2, catheter in left atrium through the foramen valve. Here, the catheter in the left atrium. Balloon inflated in the left atrium and pull back to the right atrium. The balloon pull back now in the right atrium. Okay, and the final result. Okay, it's a good ASD with the flapping of the borders of the ASD, and the mixing is better now. Okay, this procedure, this pullback, can be repeated any times how you need to achieve to have this result. Okay, with echo guidance, you see where is the catheter, where is the balloon, and avoid the complications. Avoid the complications. lesions, troubles with the mitral valve, with tricuspid valve, rupture of the pulmonary veins, okay? And then the echo guidance is important to avoid this kind of complications with the procedure. Okay, surgical management. It's different depending on the type of the DTGA. DTGA without VSD, arterial switch. In Brazil, you say Jatene operation. DTGA with VSD, arterial switch plus VSD closure. DTGA with VSD and left ventricle outflow tract obstruction, Rastelli operation. DTGA with unprepared left ventricle, atrial switch, Senning or Mustard operation, or two-stage switch operation. Just talk about the two more important surgeries. This is a poster of the 7th World Congress of Pediatric Cardiology in Barcelona in 2017 that showed the physiological repair of transposition of the great artery, the history. In 1959, Dr. Seni in Stockholm created an operation, a surgery to do the switch in the atrial level. Okay, the pulmonary vein return with oxygenated saturation are directed to the tricuspid valve, right ventricle, and the aorta, and the systemic venous return towards the mitral valve, left ventricle, and pulmonary artery. This resolve the saturation. Systemic saturation is high, it's normal. In 64, Dr. William Mustard from Sick Kids, Toronto, Canada, and I didn't know this. He started like an orthopedic surgeon, create another technique to do the to the systemic venous return to the left ventricle and the pulmonary artery, and the pulmonary venous return to the right ventricle and the aorta. Okay, this is a good surgery that keeps the baby alive for several years. The problems of these surgeries, many manipulations of the atrial tissue, and atrial arrhythmias. Okay, supraventricular arrhythmias is frequent in this kind of surgery. And other problem that we keep the right ventricle with the aorta with systemic pressures, and long follow-up we will have a heart failure of this ventricle is not prepared for the long time with the systemic pressures. And this is we are very proud of Dr. Ajib Jateni that in 1975 described the first case with arterial switch and the anatomic correct of the detransposition of the great arteries. This is the surgeon view. The aorta is anterior, the pulmonary arteries are separated. Okay, this is why it is important to know the coronary anatomies, and the coronary are replaced in the posterior vessel that is arising from the left ventricle. Okay, then it is replaced in the posterior vessel, and the ascending aorta and the pulmonary trunk are sacked and switched. Then now you have the right ventricle to the pulmonary artery and the left ventricle to the aorta. Okay, the anatomy is correct except one thing: the valves keeps in the original place. Or what I can say, the aortic valve is in the right side. Okay, and the pulmonary valve is in the left side. Okay, thank you for your attention. In Portuguese, obrigado. This baby is had the DTGA. The diagnosis was made in the pulse oximetry screen in the second day of life, and he did the Jatene operation, and now he is very good, like you can see.